Thank you for the invitation to come speak. The morning's off to a great start. Neither one of us tripped on the way up or down the stairs, so that's good. I also like to get a sense of who I'm speaking to. How many people in the room have been diagnosed with multiple myeloma or are here because of somebody diagnosed with multiple myeloma in the last month? How about one in the corner? How about in the last 6 months? Okay, now I'm actually very scared of this audience because there are very few rookies in this audience, but I will try my best not to bore you to tears with my lecture. The purpose of this lecture is twofold. Threefold. One, for the people who are relatively recently diagnosed, it's to provide them an introduction to the disease and sort of bring them up to speed on information that's going to be important to them. The second task for those of you who know more about multiple myeloma is to sort of just emphasize ideas and reiterate things that are important, not just in terms of a disease overview, but sort of emerging technologies and emerging treatments. And that brings in the third thing, the third task for my talk, which is setting up the other talks. And because I have all of those jobs, I'm very excited to give the Myeloma 101 talk. So myeloma is a common disease, actually. There's about 20,000 cases diagnosed each year in the United States. And after all of the non-Hodgkin's lymphomas that are lumped together to form the biggest slice of this pie of blood cancers, multiple myeloma is second. And what I love about this slide is the graph on your right. The 20 to 22,000 cases per year has been a pretty fixed number, but the other column, the current number of patients with myeloma, keeps going up. Now, why would that excite me? I mean, at first blush, that doesn't sound like a good thing, but what it means is people with myeloma are living longer. And so that number was 70-something thousand 5 years ago, and now it's creeping up towards 100,000 because the people who are diagnosed are doing better for longer thanks to new therapies. What is myeloma? Myeloma is a form of blood cancer. It's a cancer of plasma cells. Plasma cells are part of our normal immune system. They are the cells that make antibodies. What we have in the top corner is a sort of a diagram or cartoon of an antibody. And I always compare the structure of that Y-shaped structure in the corner. I always compare it to a barbecue fork, right? Because if you think about a barbecue fork, you know which end of the barbecue fork is the business end, right? And it's the same thing in an antibody. Those ends bind to things. But the difference is that those ends aren't just pointy ends that poke into anything. Those are more like a key. So when our immune system is healthy, we make antibodies that are directed towards specific somethings, viruses, bacteria, other allergens. In multiple myeloma, we have this abnormal clone of plasma cells, right, that's overgrowing the bone marrow, and it's producing useless antibodies. And this useless antibody is something that we can use to measure the disease, and we call that antibody the M protein. And so some of you have an M protein that's an IgG kappa, or an IgG lambda, or an IgA kappa. There's different types of M proteins. Some people actually just make the fragments of that antibody called light chains. So you can see on the diagram where the light chains are, and everybody's myeloma clone makes M proteins or light chains that are either kappa or lambda. And that's important for the free light chain testing that many of you have had. Myeloma can cause a variety of symptoms. One of them has to do with effects on bone. What myeloma cells do, and we're going to hear more about this later, I suspect from Dr. Rudman, but what myeloma cells do is they hijack the bone metabolism, and they cause lesions in the bones, holes in the bones, thinning of the bones, demineralization. And as a result, patients can have fractures or bone pain, or high calcium as a result of this. The M protein, particularly the light chains from the M protein, can affect the kidneys in a number of different ways. The most common way is for the light chains to form casts that plug up the tubules, the tubule system in the kidneys, and that causes kidney injury, which can be progressive and which needs to be dealt with quite quickly. And it's important to recognize that there are certain situations like dehydration or certain medications, IV contrast dye from a CT scan. There are certain circumstances which can actually precipitate kidney injury in patients with multiple myeloma because of those light chains in the kidneys. And then finally, if we could hit the button for me, please. Problems with blood counts is another big issue. So on the last slide, you saw that cross-section of the bone, and it's that inside spongy part of the bone where the plasma cells grow and expand, and they basically impair normal blood cell formation because that's where normal blood cells form. And so patients often present with anemia, and certainly the majority of patients develop anemia over the course of their illness. And other blood counts can also be affected. Platelet counts can be affected, which if severely affected could contribute to bleeding risk. And the white blood cell count can be affected, the neutrophils specifically. And that can become an issue when trying to deliver chemotherapy down the road because it can predispose you to infections. This is a timeline graph which is to help us discuss sort of the natural history of multiple myeloma. What we know, we just described somebody in the last slide who has symptomatic, or in this slide, active multiple myeloma. Sometimes we'll refer to those symptoms as CRAB criteria: calcium elevations, renal or kidney injury, anemia, CRAB, bone, CRAB criteria. Right? And that's the hallmark of active myeloma. And typically, when people have active myeloma, they may have 3 or more grams per deciliter of M protein. They typically have more than 10% plasma cells in their bone marrow. And by the time somebody has symptoms, the diagnosis is typically not hard to recognize. And when there are symptoms like that, that's when treatment is indicated. What we've learned over the last decade or more is that essentially all patients with multiple myeloma have a pre-symptomatic phase. MGUS, which stands for monoclonal gammopathy of uncertain significance. It's a mouthful. We'll just call it MGUS. I'll explain the important parts of that. And then there's something that's a bit more accelerated than MGUS, which is smoldering multiple myeloma. So monoclonal gammopathy is medical jargon for having an M protein. Okay? And actually, if we just did populational studies, the majority of people with M proteins don't actually have any disease that requires treatment. MGUS is extremely common, and as we get older, it becomes more common. And by the time people are in their 70s or 80s, a few percent of people who are otherwise healthy have an M protein. But if you don't have more than 10% plasma cells in your bone marrow, and you don't have any of those CRAB criteria, and that M protein isn't accelerating rapidly as it's being tracked, then you don't have something that needs to be immediately treated. So MG, monoclonal gammopathy, that's the M protein, US, uncertain significance. The uncertainty is what will happen to those people over time. And we know that people with MGUS are the ones, people who have myeloma all develop from people who have MGUS. But not most people with MGUS don't go on to develop multiple myeloma. About 1% per year. And you can do some testing to perhaps identify a higher risk population that may have a 3 or 5% risk per year. And as it accelerates and the bone marrow plasma cell count gets higher and the M protein gets higher before there are symptoms, that's when we call it smoldering myeloma. Smoldering myeloma is often viewed as a transitional stage between MGUS and myeloma. And so the risk of developing symptomatic or active myeloma within each year is about 10%, at least initially, with smoldering myeloma. So you can view MGUS to smoldering myeloma to active myeloma as stages of a disease evolution. And the reason that we don't have any units on the time axis on the bottom is because it's highly variable for different people, right? Some people have MGUS for 15 years and then develop myeloma. Some patients go from MGUS to smoldering myeloma to myeloma within a year. And a lot of patients are diagnosed or recognized to have a problem for the first time when they actually have myeloma, and they never had blood testing for any M proteins before that. So any of those scenarios could be seen. Next slide. So when multiple myeloma is suspected, these are the tests that we do to try and establish the diagnosis. Most of the people in this room presumably have had these tests. I'm just going to go through them pretty quickly. We look at blood counts for the reasons I mentioned above. We do a test for the M protein called serum protein electrophoresis with immunofixation. That's what we're seeing in the bottom right. Okay, so what we're doing is we put a drop of serum or a drop of urine on a plate, an agar plate, and we apply an electrical current, and the proteins separate apart. And you can, so you're basically taking a drop of serum that has all the proteins in it, and you're separating them. And they separate into these colored bands. They're not really colored. This is a cartoon. But the graph above it is a graph that gives you sort of like the quantity of the protein in each of those bands. And that big spike that's labeled M spike, that's the M spike, and the dotted line under it is what that spike would look like normally if you didn't have multiple myeloma. Okay, so that's a serum protein electrophoresis, and you could get a very similar picture on a urine protein electrophoresis. We also do other blood tests, blood chemistries. We do tests like beta-2 microglobulin and albumin to stage myeloma. LDH also provides some prognosis about myeloma, and we look at things like the creatinine to look at kidney function. Another test that I mentioned previously was the free light chain assay, or the free light test, and that's to look for those little fragments of M protein. Some patients only have that fragment as their myeloma marker, but a lot of people have a light chain elevation in addition to an M protein, and both of those are typically followed when we're tracking how somebody's responding to treatment. Next slide, please. So we also do imaging. Traditionally, the imaging is a skeletal survey. A skeletal survey is head-to-toe x-rays. Skull, spine, pelvis, and the long bones of your arms and legs. At some centers, the ribs. At our center, the ribs are typically captured as part of a chest x-ray, and we don't do dedicated rib films. It's a little hard to see because of the light up here, but and I don't think so. I'm gonna walk away from the microphone. Well, no, the arrow on the X-ray is pointing to a vertebral body that's flatter than the vertebral bodies below it. You can see those nice square, high vertebral bodies in the spine below it, but then all of a sudden one is smushed, crushed. That's a compression fracture. That's a very common presenting skeletal complication in multiple myeloma, and a significant percentage of patients with myeloma over the course of their illness develop those. It's easy to see something like that, and you can also see, just to give you a higher resolution picture, let's just skip over to the CT scan, and you can see, again, one of these things is not like the other, right? There's a bone there that is significantly compressed compared to the ones above and below it. That can be a cause of pain and also deformity. And so height loss and progressive bending over, that's kyphosis, right, is the result of multiple compression fractures. And the problem with those fractures, besides the fact that they hurt, is because of the way they change the curvature of the spine, they put the bones above and below those fractures at risk for also developing fractures. So it can become a vicious cycle of spinal problems. the thing you can't tell from the X-ray or the CT scan is how old that fracture is, and you can't tell how active the myeloma is in any given bone. So there are other types of tests which give us information about that. There's functional imaging, and a PET scan is a great example of it. And you can see on the PET scan, now there's no arrows. This is when I'm really actually going to walk away from the microphone and just talk in the voice that I talk to my 4 children in right now. So you can see that there's a deformity here with a lot of curvature, and there's also a hot spot down here. There's 2 bones that are compressed. One of them lights up on the PET scan, and one of them doesn't. So the one that's lighting up suggests that there's something active metabolically going on there, because the tracer, what's lighting up is a radiolabeled glucose. So sugar is accumulating in that bone. So something that is with high metabolism is happening there that isn't happening in the bone above that isn't lighting up. So it suggests that there's an active lesion or an acute fracture with inflammation down below, but the one up top is probably an old compression fracture because there's nothing happening there on the PET scan. So the other test that many of you are familiar with, and I'm sure appreciate greatly, is the bone marrow biopsy. This is actually a bit of a hard picture to sort out. But as you all remember, bone marrow biopsies are typically done the posterior part of your pelvic bone. You're typically laying on your side, sometimes on your stomach, sometimes knees bent. But what it does show you is the instrument that we use to actually do the biopsy. So traditionally, we use this needle with a handle, and we just kind of, once everything's clean and numb, we can push the needle into the middle part, that soft part of the bone, that's the bone marrow, and that's where we get 2 different materials. We get a liquid part. That's the part that really hurts. When they do the 3, 2, 1, take a deep breath, bang, hurts for a second. That second is when they're applying negative pressure on the bone marrow biopsy and taking out the liquid part. And then after that, they're getting the solid part. And both of them are useful in assessing the amount of multiple myeloma cells that are in a sample. That liquid part is what we're using, what we often use to analyze the genetics of the myeloma cells, and in projects like the COMPASS project that we discussed previously. Now there are some centers that are using actually a drill, a bone marrow drill. Has anyone had one of those ones done, like a before and after? One manual, one with the drill. Anyone? Which one's better? I was almost 100% certain that was going to be the answer. That's kind of the word I'm hearing too. Is it is a slightly faster procedure with the drill, but it doesn't fundamentally change what patients are experiencing otherwise, at least from what I've been told. Next slide, please. So I mentioned before that we stage myeloma. We use 2 simple blood tests to stage myeloma, and we put patients in a 1, 2, or 3. And unlike, when we think about solid tumors, staging and prognosis are tightly linked to spread of tumor, right? So higher stage breast cancer has lymph nodes involved. Highest stage breast cancer is spread to other organs. Multiple myeloma is a systemic disease right from the outset. So you can't think about it as spreading. You just sort of have to think about disease burden and disease biology. And that's what these tests give us insight to. Stage is something that you do once. You do it at diagnosis, and you don't stage and restage patients over the course of their illness. So you don't reassign stage later. Stage is the hand you're dealt. And there's nothing we can do about the initial stage. But it's important to remember when you're looking at survival curves, which are readily available online and in information books, is that those are curves describing what happens to thousands of patients. It doesn't describe what happens to one patient. So, it would be better to be the last person off the stage 3 survival curve than the first person off the stage 1 survival curve. I think we can all agree on that. And so what I tell patients to focus on, because they invariably ask, right? They all want to know, what stage am I? We talk about it for about 10 seconds, and then we talk about the fact that our goal is going to be to keep you on the survival curve that you have found yourself on due to your stage. And if we play our cards well, you'll be on that curve for a very long time. And that's the goal. So I really encourage patients not to get too hyper-focused on the stage, at their initial stage, honestly. Next slide. I talked a little bit before about chromosome analysis and genetics, so just a quick reminder. Cells have a nucleus in the middle. The nucleus has chromosomes in it. Chromosomes have DNA. DNA is the template for proteins that we make, and multiple myeloma cells are characterized by lots and lots and lots of cytogenetic abnormalities. Numerical abnormalities are quite common. 46 chromosomes is normal, but patients with multiple myeloma may have many more or many less. And also missing pieces of chromosomes and also traded pieces of chromosomes between one chromosome and another are very common, as I'll show you on another slide. The picture at the top is the sort of conventional karyotype or chromosome analysis that all of us saw in our high school biology book when we were learning about things like Down syndrome and things like that have numerical abnormalities. That type of analysis depends on dividing cells and typically looks at about 20 cells. It's very good for detecting numerical abnormalities or really big abnormalities. It is not so good for detecting small, subtle abnormalities. FISH testing is a more sensitive technique that uses probes. The disadvantage of FISH technology is that you'll only get information about the targets that those probes are looking for, but we have a lot of different probes. And so we are able to get a lot of information from FISH testing. And as I said before, it turns out the majority of multiple myeloma patients have chromosomal abnormalities when you use the more sensitive techniques. And now we're moving into an era of gene expression profiling. How many people have a MyPRS score? Anyone had one done? Nobody in Atlanta is getting that test done. Okay, so there are commercially available tests for gene expression profiling that are being done at some centers. The problem, and these provide prognostic information. Okay, these put you in the majority of patients end up in a standard risk group, and there's a subset of patients who are in a higher risk group. The problem with the test is the information does not really help you make treatment decisions unless you have studies that are specifically designed for standard risk and high risk patients. But otherwise, when you're getting standard therapy, the gene expression profiling, although it is interesting information about your myeloma, doesn't necessarily guide treatment in 2015. Next slide. We are moving beyond gene expression profiling, and we're actually starting to do whole genome sequencing. That's the basis of the COMPASS study. The COMPASS study was already discussed in some detail, so I'm not going to go into it a lot, but what the COMPASS study is doing is collecting samples of myeloma cells from 1,000 different patients at baseline and over the course of their myeloma as they get treatment, and doing whole genomic sequencing on their myeloma cells at all of those different time points to see sort of what happens genetically to the myeloma cells over time, and also what genetic abnormalities predict response to treatment or failure to respond to treatment. So this is and this data is going to be available for researchers anywhere to play with because it's on a publicly available portal. Very important study, and we're almost done with it. And Sagar's leading that study, just in case nobody picked up on that. He's actually the principal investigator on that study, so an important effort. Next slide. I talked about genetic abnormalities, and I said there's lots of them. Well, here's a fraction of them. These are the most common ones, and we do sometimes use these We often use these to assign a patient to standard risk, intermediate risk, or high risk. And I just want to bring your attention to the one in the middle, the T414 abnormality. And the reason I wanted to bring that to your attention is it's an example of an abnormality which in some respects guides treatment, because 10 years ago that was in the high risk category. And what we've come to realize is that if you include certain therapies, namely bortezomib or proteasome inhibitors, it shifts it into an intermediate risk category. And so we are learning that when in the presence of some cytogenetic abnormalities, certain treatments are necessary. We also are going to start having targeted therapies for the abnormalities that these chromosome changes result in. And again, the 414 is a great example of that. There's actually targeted agents that go after the molecule that's dysregulated because of that translocation. Next slide, please. So this is kind of the wrap up. I have about 3.5 minutes left, and I just want to sort of briefly go over treatment because we're going to hear a lot more about treatment in some detail. Next slide. Currently, going back to that evolution, paradigm that I talked about, MGUS, smoldering myeloma, and active myeloma, we generally don't treat patients with MGUS, again, because the majority of them are never going to go on to develop active disease. But when somebody has smoldering myeloma, particularly smoldering myeloma with an M protein that's rising, you might consider treatment. Certainly we have ongoing studies examining this, and there's been at least one study from overseas which did examine early treatment with lenalidomide that seemed to show some benefit. The study was not a perfect study, but it was provocative, and there are efforts to duplicate those results on ongoing studies that don't have some of those flaws on this side of the Atlantic Ocean. Once someone has active multiple myeloma, treatment's required, as we mentioned, and that could range from immune therapies to standard chemotherapy to stem cell transplants, and increasingly we're using maintenance therapies, either in association with transplant or not. And I think you'll be hearing more about that from others. The one thing that I do want to touch on, there's very few things about this slide deck that I disagree with or want to modify significantly. The thing about bone loss, I think you could have that bottom orange box. You could have a very similar orange box in the MGUS column. First of all, MGUS, again, occurs increasingly in older people who are prone to osteopenia and osteoporosis. And there's been some epidemiologic work looking at the risk of fractures in people with MGUS and smoldering myeloma compared to age-matched controls, and even compared to the similarly aged people who are already at increased risk for fractures. People with MGUS seem to be at an even higher risk. And so, particularly if the skeletal survey suggests that there's thinning of the bones, or particularly if a patient is of sort of slight build, I have no idea what my colleagues do in this. I personally have a very low threshold for doing bone density studies, and I look for reasons not to treat MGUS patients also with bone strengthening agents because they really are at increased risk for fractures. Next slide. So treatment goals in general are to reduce the myeloma clone in the bone marrow. By doing that, you will often alleviate symptoms. Some of the abnormalities or issues that we talked about, like kidney problems and blood count problems, can get better with treatment. Bone pain often gets better with treatment. If you get nice, deep control and can maintain that, generally speaking, you will prolong a patient's survival. Even the high-risk patients that in those previous slides live longer than patients were living 40 years ago with multiple myeloma because of modern therapies. So while the modern therapies don't overcome all the risk, they've certainly led to improvements in outcomes compared to our historical expectations. Next slide. go through all the, there's a lot of animation here that I have no control over, so perfect. So, so for 40 years or so, 30 to 40 years, there were hardly any new therapies introduced, basically different iterations of chemotherapy culminating in very high dose chemotherapy, which is what an autologous stem cell transplant is. But in the last 10 years, starting with thalidomide and bortezomib, which is Velcade, and lenalidomide, which is Revlimid, we've had this rapid acceleration in drug approvals, and these are drugs that are currently approved in multiple myeloma, some of them in combination with other ones in this group or with older ones, but these are the approved drugs, and you can see, you know, Feradak was one just approved this year. Next slide, please. But this is the emerging picture that we're learning, and the purpose of this slide is not to start, you know, drilling down on any of the specific pathways or molecules or anything like that. It's just to show you how complex what's going on in the myeloma cells, the blue cell that says MM cell, myeloma cell, inside the myeloma cells, on the surface of the myeloma cells, and around the myeloma cells. The other cells in the bone marrow microenvironment contribute to the myeloma cell's ability to thrive and grow and resist therapy. So we are currently targeting all parts of this picture, ranging from the myeloma cells themselves to the way the myeloma cells interact with other cells. And if we could go to the next slide. So there's this big red screen that says time's up right down there. But you can see that starting after 2015, heading into, and we're just talking about the next 2 or 3 years probably, we have a lot of brand new classes of drugs that have been shown to have legitimate single agent activity against myeloma in early studies. And I think some of them, particularly the antibodies in purple, particularly the oral proteasome inhibitors, and I think what has a lot of people excited, other immune therapies, like the CAR T therapies in the top corner, these are extremely exciting and promising therapies, and these are all coming rapidly. And so, you know, we're going to have a lot of new agents to incorporate into our paradigm, and hopefully what we'll see as we go forward is the survival curves getting pushed out further and further and further, and hopefully with less need for cycling through all of these therapies over that time. Hopefully longer periods of disease control as we start incorporating the new agents. Next slide. This summarizes everything I just said. I will just hit these points quickly. Multiple myeloma, as we know, can cause lots of problems in our bodies, which we need to be aware of so that we can avoid certain circumstances and anticipate those problems. We are learning more and more about the genetics of multiple myeloma, and that is going to be used to guide new treatments. And as we develop these new treatments, we're having increasingly improving survival. I believe that is it. Yeah, so the question is, does chronic use of steroids, you know, again, I mentioned in passing, we're doing maintenance therapy increasingly. So patients are on therapy more continuously and longer than ever before, which is leading to improved disease control. But do certain drugs, like so could steroids, lead to bone problems? And I'm almost scared to answer this question in front of Dr. Rudman, who is a world's expert on this topic. But I think the answer is yes. We know that steroids can have a negative impact on your bones. So what we're always trying to do is hit the right balance, because so the competing risk for your bones is the myeloma. And so I think most of us believe that if the myeloma is active, that poses a bigger, you know, getting control of that, you know, it has to take priority over the potential, that kind of a potential long-term consequence. And so, but that's the exact kind of, you know, question that factors into, like, so what do you do for maintenance? You know, are steroids necessary as a part of maintenance? Generally, I don't use steroids for a prolonged period of time as part of maintenance, mostly because A, most of the trials haven't used steroids throughout the maintenance period, but B, we know that it has long-term side effects, and most of my patients would probably kill me if I told them I wanted them on long-term steroids. So, generally speaking, we try to avoid it. Thank you.